So we actually have another demo, and specifically on this topic. So we're really fortunate. We have Dr. Glen David. Hey, Glen, how are you doing?
Good. How you guys doing today?
So Glen has, in the lab, he's got Yev Fravert, who's one of our fellows, and they're going to talk about vertebroplasty, kyphoplasty, and then you're going to show us a little bit of ablative procedure. Is that right, Glen?
That's correct, Rod. We have a demonstration here how to access the pedicle safely, and then how we can use that access to place some probes for a possible radiofrequency ablation for spinal tumor metastases.
Great.
Yeah. So we have Dr. Fravert going to access the pedicle here. Right now, we're going to look at accessing the AP view, the standard approach to doing a bipedicular approach. As you can see, if we can pan in on the AP view for the imaging there. We start pretty much at the 2 o'clock position. Outside.
So we're really lucky because we have Dr. David and Udi and Mark. I think you guys probably have a guy. You got to have one person who is going to do, I think Glen does hundreds of these for us a year.
Yeah, but a lot of the previous comments earlier, and the fact that, a good discussion with the team and with Rod or Jens in terms of which patients are candidates for kyphoplasty or even radiofrequency ablation. As was said earlier, some of these patients don't have pain from their spinal metastases, and it's a different type of mechanical pain, and it's important to get a good examination of the patient and imaging to see, well, is this really what's causing their pain? I have a picture there. So our typical approach actually was, especially in the AP view, because we're trying to access the actual area in particular. So let's grab it here. We're going to go from the more 2 o'clock position and point towards actually, and we're going to go towards the opposite actual vertebral end, opposite corner. And so we're going to start more at the 2 o'clock area of the pedicle and access it that way in this type of approach.
So Glen, are you doing a vertebroplasty or a kyphoplasty?
So we're going to be doing a kyphoplasty, so a balloon kyphoplasty in this scenario. So I know a lot of times people are like, well, what is vertebroplasty? What is kyphoplasty? Vertebroplasty is simply accessing the vertebral body with a trocar, removing the stylet, and then injecting the cement. Okay. So with that, you have an increased risk of extravasation occurring. Quite a high rate, anywhere from 40% to 75% with vertebroplasty, with some of the papers quoting. With kyphoplasty, you're creating a cavity. With balloon kyphoplasty, you're creating a cavity. So with that, there's area for the cement to not only provide some height restoration, but also to help reduce kyphosis, which kyphoplasty, I'll back it up a little bit. We'd probably want to make sure we're taking a lateral before we're crossing the medial pedicle line there.
So yeah, as you can see, Glen is extremely meticulous, and you can't be off at all on an AP view, otherwise he'll make you redo it.
Get a lateral there. So see, we're pretty far outside. So before crossing the medial line there, we want to make sure we're about to enter the vertebral body. So, which means right now we are fairly medial in terms of our approach. So we want to approach it a little more parallel or more lateral approach, and maybe a little more outside of the pedicle in coming at it. Let's go back to AP. That's why I usually approach it from anywhere 2 inches lateral and 2 inches superior to actually we're going to access the pedicle. So here,
go even further out.
Yeah. Let's go out.
Here, let me reposition that entirely.
So Glenn, what's that little machine next to the?
So let's have a little glimpse of the osteocool from Medtronic. It's a device which is used to ablate any tumor within the vertebral body. You can depending on that. Excellent. So eventually we're going to get the took our needles and therefore the probes in this fashion here. We're going to take a look at, well, this is a piece of chicken here, and the osteocool device, what it does, it distilled water is funneling through the tip of the needle so that it takes away and takes away the heat from the surface of that probe, so you're not providing char to the tissue in that area, and provides a heat sink that area, which provides a larger ablation zone.
So how warm does this get?
So
if it can cook chicken,
so the bronze area goes up to 95 degrees,
Wow.
and these areas both distally and proximally go up to 70 degrees.
And then what is the, so the irrigation cools the tissue so it doesn't get too hot?
Yeah.
So you don't want it to be well done?
Yeah, so there's a distilled water funneling through that tip of the needle there, so that which cools off
Wow,
the tip
you
of
can
the
see
needle
it
there.
cooking there. Is it cooking right now?
So we're providing a little, so that's going to be your lunch today, Rod. So,
I like sashimi. I think I'll stick
go
to
back to
sashimi.
AP.
And then probably a more cranial angle.
Yeah. Have a look.
So Glenn, Linda's going to get mad at us here if we don't
Why is that?
Show us a vertebroplasty. There we go.
Okay. Let me provide here. Let me have a look.
And let me ask you, so right now you're doing a vertebroplasty. So
Picture there.
do you always go bilateral or do you go unilateral?
A lot of times I will go unilateral if we're getting good access, but in terms of providing a good ablation zone, it's good to get actually doing a biparticular approach, depending on how big the tumor is you're trying to ablate.
Did you just steal the vertebroplasty from
I
Yale?
was going to get a
No,
little
I'm on
more,
the
get them
other
started here in the right
Yes,
fashion.
Yev needs another year.
Yeah.
There. No, well, you know, in spinal
We have to
you're
go to
accessing the pedicle quite a bit differently, and that's the
So this is a 2 o'clock approach.
exactly it. As
You did
I'm
not
meeting
like the
the
3
medial
o'clock.
medial pedicle line. Let's go to a lateral now.
You didn't like Yev's 3:30 approach. You wanted to go 2 o'clock.
Yeah, 2 o'clock. You know, approximately.
What? Yev, did you see that?
Yeah, it's a completely different angle than
Wow.
we usually
Yeah,
use.
so
for
I'm still
strip
at a very medial. Let's go back to.
I think that I think it's very important that when you put the needle on the AP, what you can get
Picture
into the. Can you hear me?
Picture
Okay.
Picture there. I'm just going a little too medial. Picture there.
I mean, what I try to do, Udi, that's a great point, is I try to square up the end plate that you're working at, and then put the
Let's have a look. Picture.
put the cannula so it's parallel to the end plate.
You can start accessing the other side though.
Yeah, I mean, I think the key is that when you reach the medial wall of the pedicle
Yeah.
on an AP view, you want to be at the back wall of the vertebra. That's the danger zone. So that's guaranteed that you are through the pedicle all the way down to the vertebral body. As long as you have to check it on the lateral.
Shortly.
On the lateral.
Actually, 1 second.
Glenn likes to work in the danger zone, I think.
Yeah, well, I'm staying at that medial line of the pedicle there.
Let's take a shot.
But you really have to, Udi, I agree with you, and I think Mark mentioned this, is
Yeah.
you have to have someone, I mean, Glenn does hundreds of
Let's go
these a
more
year
lateral.
for us, and
Yeah.
you have to have someone that's, I think, and again, I'm biased, but I think, we're so busy doing surgeries
Shot.
that you have to have someone that can get these patients in the next day, same day, and can do these, and I mean, all our patients go home the same day. It's done
But less medial,
outpatient,
let's go more.
and it's really become. And I think
Access better.
both you, Udi, and Mark, and Larry, and our center here.
Great.
It's really you have to have a team approach to do this, and I mean, it's procedures like this, where Glen literally this is all he does, and he's so good at it. There's no way any of us.
Let's go
Compete with
lateral.
him. And the other thing too is, I think there's so many different companies that provide, this technology, and even in the cement, and how the mixture and how how the viscosity and all those things play an important role.
That one's actually in line. The other one's so much. Let's go AP. The one that, I think it's just too far. Picture there.
So some of those tricks is to start very lateral, and as you start advancing the needle, you sometimes can do it extrapedicular and then being able to reach the vertebral body itself
Let's come up more
and
lateral.
bypass the
try and get
danger zone
access
where
to
the
it.
canal is.
Try that.
I typically would use a unilateral needle, and I cross the midline on the AP, and then inject
right
the
there.
contralateral side,
Feel
and then
the-
pull
feel
the
the bone
needle
there?
up a
Picture.
little bit, and then inject the ipsilateral side.
Picture. And to access the area, we want to provide less medial orientation to it. Picture.
So Glenn, just for the interest of time, do you want to just why don't you do your side so we can see it?
Yeah.
And then
Get the out for now.
we're going to make Yev
lateral for me?
repeat his fellowship, I think at least for 6 months, maybe a year.
Picture there.
I'm not sure we have to be that harsh, but we may
So
have
yeah,
to
as
give
you
him
see,
an
we're going
analog.
to be accessing the vertebral body here. I'm in the AP view. I've met right up to the medial line of the pedicle, and you can see in the lateral view, I'm about to enter the vertebral body. So that's optimally what you want to be doing as you're going into from a uniparticular approach. So I'm entering. Picture there.
But Glenn, don't you want to be? Are you going you're angling too far? I think inferior, right? Or is that where you want to be on this one?
Picture there. That's a decent approach. But also depends,
Okay.
Rod, of course, also
Okay.
where the actual tumor is.
So you're right
at.
in the center of the vertebral body there.
Yeah.
Okay, great.
This point, we're coring it out with some.
Should we let Yev redeem himself?
Better. Picture there. See how the depth of it. There you go. And there's a little marker there and how deep we should go. Pull
Take
it
a
back. Great.
And aspirate.
Oh, there he is.
And pull back.
Yev is back.
All right.
Go ahead and pull the sample straight out.
Sure.
So this helps to core out the area. Then we're using
So what did you just
Drill.
do, Glenn? Did you take a biopsy there?
the biopsy there. A lot of times they're definitely always sending it up for pathology. What's the lateral? So we're right there. So this drill helps to, go ahead, picture the drill there. Can you see it on the camera
Yeah,
there?
that's great.
Let me give a lateral view of it. There's some markers there, anyway, are color-coded to help determine what size probe we're going to use. And then now we're using the probe,
Right there.
you're pulling out the actual drill. Now you're placing the probe, which is, we're placing at 70, 95 degrees, and distally 70 degrees, which we see on the chicken sample. At this point, you would do the ablation in a number of approximately 6.5 minutes, and we're looking at, 15 minutes, and we're actually then going to proceed with the actual rest of the kyphoplasty now. So with this company, Medtronic, as a curette, and as you can see here, helped to provide some actual coring out the actual vertebral body even further before we use the balloon before we inflate the balloon. We're going to use a 15 millimeter balloon on this side in particular. Now look at the actual radiological view. Picture there.
What's in your hand there, Glenn? That looks like a gun.
Yeah, it's called a curette, and it's used to core out the
Oh, wow.
the vertebral body even further. You can lock it in as well. And it's used to provide even further space. Sometimes you'll have some different bony shards in the area of the balloon. You want to maybe smoothen it out. It helps the cord out even further and provide some further cavity. So let's go back to the AP view. So a lot of times in a regular kyphoplasty rod, I'll use this to help get across. Picture there. In a particular fashion. Picture. So I'll use the picture there.
Oh, that's
a lot of times we'll
that's a
core it
great
out.
picture.
Picture there.
Let me go live.
Picture
Let's
there.
see.
Live.
Wow.
We'll core it out.
Okay.
And do it at different depths, of course. And you see I'm crossing midline there, and which enabled me to get the balloon across as well. Picture there. Live. Of course, this bone is not osteoporotic, but it's a lot of bone shards providing a lot of some resistance here. But of course, being careful not to cross any of the end plates there. Picture there. And finding different depths. I'm going to back up my trocar a little bit. Picture there. Picture. Picture there. The cement going? That's good. Thank you. And then I'm removing. So yeah, removing the actual curette. And Dr. Freyer is going to insert the 50 millimeter balloon. Maximum capacity for PSI is 700 PSI, or 4 cc's of contrast within the balloon. Let's take a picture. Let's do the picture first. Enter further. And you want it outside the trocar picture.
Take a shot.
Let's go maybe lateral now. That's straight. So, but there's an alternative at this point also to go to a curved needle rod to bring it even further across. So we can get even further across in a uniparticular manner. And as you can see here, I'm not sure if you can see that.
But do you really need the balloon now, Glenn?
If you're trying to provide some height restoration, this is the only way we're going to be able to do that, at least for balloon kyphoplasty. Of course, there are, as you're going to show later on today, some of the spinal implants used to provide some height restoration in vertebral augmentation with the spine jack. But this, for balloon kyphoplasty, yeah, this is a great way to provide height restoration and reduce kyphosis. If you want to look at the lateral view of the fluoroscopy, Dr. Freyer, it's inflating. Where are we at now, PSI?
About 350.
With 350. cc's of contrast in so far, about 1.5.
Yep.
Max capacity of that balloon holds is 4 cc's. So picture there.
Let's take a shot.
Excellent. A little more. We're staying away from the picture there. End plates, it's up there. Let's have a look at the AP view.
Twist that counter when you take it out. Twist it counterclockwise till you get to 100, and then you can squeeze that gray handle and pull off.
Picture there. So yeah, somewhat across, but you can get across even further, as I said, with further inflation of the balloon. Of course, being careful of the inflating under a lateral view, but also checking the AP, staying away from the end plates as well. But
Go a little bit more.
I was talking about the a little bit more, yeah. Picture there.
Let's take a shot.
Let's check the lateral. Where is the cement?
Cement's ready to go.
Some alternatives, as I said, Rod, is using a curved needle if your vertebral body is heavily collapsed, which unfortunately sees that quite often. From 60 to 70% collapse of the vertebral body. There's not a lot of room for balloon kyphoplasty. So me pull back now. So what is the role of balloon kyphoplasty in some of those cases? Well, you're not able to inflate a balloon of this size. Maybe a smaller balloon is an alternative, okay? Or using some of the tools that we talked about, like a curved needle, to get across and provide the cement across and within a smaller area. Okay. But at the same time, you're creating a cavity. You're not just inserting a needle and injecting, like in vertebroplasty, which has a high extravasation rate. You're providing a cavity for using an augmenting device like a curved needle, like a lot of these companies have, to provide the cement across that very heavily collapsed vertebral body. We're removing the balloon now. We're going to get the cement here. So there's cement. We go through the slide of cement. This is the X-Speed cement. We're going to show the slide shortly here. The X-Speed cement from Medtronic that has a setup time of 8 minutes before we have a high viscosity cement that we can deliver up to 16 cc's of deliverable cement.
Let's take a shot.
I'm going to push that further in.
Gotta advance that.
Yeah. And you can actually see the outline of the actual balloon kyphoplasty, balloon inflation there in the lateral view. Picture there.
Proceed.
And go ahead.
Good.
So this, we've already had the cement sit for, after it's mixed for 8 minutes. Now we're delivering the cement. Of course, you check the cement itself, making sure it's not sticking to your glove, making sure that the sheen of the actual cement is no longer shiny. A good way is to check, make sure the cement is ready. Picture there.
Let's take a shot.
And keep going. Every few seconds. And pulse view of the lateral view of the cement being delivered. Go ahead. And this canister will hold 8 cc's of cement, the speed. Their older cement was more of a low viscosity cement, but if you want to bring up that slide for the different cements, we will shortly.
Probably pretty good there, a little bit more.
Add a little bit more. Keep going.
So you really did a unilateral approach, but then accessed the bilateral.
Well, let's see on the APV rod on how much you were able to get across. And, yeah, a majority of the approaches I use is of a unilateral approach, but
let's take a shot.
Sorry again.
That looks good. Yeah, I feel guilty now that I was so hard on you. That actually looks very good.
Proof is in the pudding.
Okay. Will you forgive me?
We'll see. All right.
All right.
Good?
Yeah. If you want to bring up the slide regarding some of the cements here, it's just some example of some of the cements that we use and most commonly used, at least.
Oh, wow. That's great.
So we talked about the Medtronic one. We were using X-Speed here down on the bottom there. 30% barium, working time of 18 to 20 minutes. Setup time is 3 minutes. Fills, the bone filler is about 6 minutes. But it's a high viscosity cement. Compared to their Activos cement is about a lower viscosity cement. Setup time is 8 minutes, but a similar working time. The newer Striker cement has a quick setup time of 60 seconds, similar as our older cement. But the Vertebroplasty cement is their newer cement, a high viscosity cement as well. And delivers cement is about up to 12 cc's of cement, but a working time very similar to Medtronic's, 20 minutes. But the steel billow bone merit, I think today you're using the Vertebroplasty cement today, but the stability bone cement for merit has a working time of 30 minutes, but they're also using a generator to provide RF energy to that low viscosity cement to provide a high viscosity deliverable cement. That's a setup time of 5 minutes. And of course, the confidence DePuy, also a high viscosity cement, of up to 10 cc's of deliverable cement. Okay?
That was great. Thank you both. What a terrific demo.
If you want to go back and have a look at the
Yeah, let's see what the chicken looks like.
before you barbecue it up, Rod.
Wow.
Oh my gosh.
So, Glenn, we can't identify the patient, and I didn't bring the slides of that, although I could download them for later.
Yeah.
But you may well remember this breast cancer lady.
Yes,
with
yes.
breast cancer L1. You did a thermoablation on her. Very concerned patient. We really wanted to avoid surgery. 80% vertebral body destruction. I just saw her in clinic the other day, and she looks amazing. The CT scan 1 year out looks fantastic. I got to share the images with you. She's very grateful, very, very happy. So on this N of 1, this worked like a charm, I have to say.
Yeah, in the right patient, as we talked about earlier, patient selection is key here. In the right patient, it can be quite helpful to help with their pain with a less invasive procedure. You know.
Great. Thanks, guys. Really appreciate it. That was a terrific demo.